Well, good afternoon, everybody. Thank you for joining us on SEVA VentRounds. Today, it's a little bit of everything, but there's a lot of effort everywhere, and you'll get the feeling as we start going through them. The usual disclosures, we will discuss particulars of ventilator modes, no endorsement of any particular mode, manufacturer, or any company. Whatever we say, it's our opinion. It does not represent the Cleveland Clinic. I'm Eduardo Mireles, and these are my disclosures. And Rob Chatburn also co-directs this activity with me, and these are his disclosures. So the ground rules, this is recorded and it becomes available in YouTube in the next 24 hours. So just keep your microphone muted. The moderator, I myself, may call upon you to comment on items that are going on, or if you put post a comment in the chat from WebEx, that's very useful because then we can read it, and if we need some clarification, we'll just ask you to comment on it. And it makes it relatively simple and painless, and that way everybody can be part of this. We're not using the WebEx poll today, and at the end of the episode, there's CME for the Cleveland Clinic employees for all of you to visit. So let's get started, and we'll start with. We're back in COVID season, so we have a lot of fresh images from the bedside, and here I have one for you to think through it. So there's no poll, but I want you to think what is the tag, what actually is happening in this, what type of mode it is, what is the load, and if you see any patient ventilator discordance, and we go in order: trigger, inspiration, cycle, and finally expiration. And after that, we'll ask for input regarding if there is any changes that you would like to do to the ventilator after it. So let's start reading this one. I know, Uri, you wanted to get started with this one, so I'll give you the whole honor. So go for it. Uri is one of our fellows. And we're all ears, Uri.
Can you hear me?
Yes, Uri.
Okay. So I think this is I can see the flow waveform, and the flow waveform is machine control. So I would use the volume control. Then I would so that's my target control variable. Then looking at the breathing sequence, I think this is mandatory. So I would say CMV. And then I would say S because everything is set point. Load-wise, looking at the time constant, especially for the time constant seems to be pretty small, and it goes and the flow waveform and everything goes back to the baseline. I do not see any PMAS. There is no really patient interaction. So I would say mostly elastic. It is very rare to have inspiratory and expiratory different loads. So both inspiration and expiration would be both elastic. Trigger wise, I think this is normal. I don't see any late, early, failed, false triggers, and essentially, there is no patients. I would say there is no PV discordance. I was just thinking about this last night while preparing something, that the only PV discordance that can happen without any patient or any PMAS would be a false trigger. So if there is no PMAS, the only discordance I'm going to look for is a false trigger, and there is none.
Fabulous. Great job, Uri. That's correct. This patient doesn't have any activity. So let's go in order. And I put this one because we see these ones now and then, and they are, I would say, relatively distressing for the patient and for us as clinicians. So you're absolutely right. This is volume control. You can see the flow is controlled throughout the inspiratory cycle. It's controlled, it's continuous mandatory ventilation, and that is every breath that we can see here is mandatory. And so the sequence, at least on this picture that I put in, which I don't put any other settings or anything else, the best that you can say is that all of them are mandatory. So it falls under CMV, and it's set point because you set the flow that the patient is going to get on the inspiratory time, i.e. the volume that the patient is going to get, and that's what the patient is going to get. You set everything. It's the most basic targeting scheme that we have available. In terms of load, you read this appropriately. If you look at the inspiratory phase, the first step up, so from here, from this point to this point, all of this rise is all resistive load. It's a straight, the flow goes rapidly up, the pressure goes up when it encounters the resistance of the airways, the artificial and natural airways. And then the slope of how this elevates, and it goes from this point all the way to the rest. So all of this area is your elastic component. So actually it's the slope is the elastic component. We know that if you do a pause here, it would drop the same amount that it drops here. So this is the slope is essentially your elastic. And you can see that for this amount of inspiratory time, the pressure changes a lot from the beginning all the way to the top of the pressure. And so this combined with the return to baseline in less than a second is consistent with an elastic load, a very high elastic load, to the point that if you see the amount of pressure that this patient is requiring for that amount of tidal volume, he's getting around 400 of tidal volume, and he's requiring almost 40 of inspiratory pressure. So his compliance is probably around 10, 15 centimeters of water. So pretty stiff lung on this patient. So well done there, Udi. And then you have the PV discordance, and you recognize that you could not see any PMOS. And in absence of PMOS, essentially it's very difficult to have any discordance. And the only one that you could potentially see is false triggering. That means an asynchrony, which there is no PMOS, and there is triggering by of the ventilator by a signal that it's not a PMOS signal. It can be secretions, the heart, you name it. Those are some of the triggers. So would you change anything on this ventilator right now, Udi?
Okay, so the need for the patient is, I mean, I need to reduce my plato pressures. I think that's the one. And to reduce my plato pressures, my tidal volume is 450. I think the first thing I would do probably is reduce my tidal volume.
All right. So you would you're now concerned that this patient has very low compliance, and that you may be over-distending some areas, so you want to decrease the tidal volume, right?
Yeah.
All right. Any other comments from from anybody? Would you change anything else on this mode right now, or would you leave it like it is? So Miguel Ibarra asks, is it justified to diagnose a high stress index according to the pressure time curve? So both great questions. There's also another question from Dilip asking about the respiratory rate, and it's close to 30. So if this is 1 second, he's getting around 30. I think he was 36 breaths per minute on this one. In terms of actually, that's let me go back to the stress index, and there's a manuscript out there in which they put they used a credit card or a badge, just like mine, and they put it in front of the screen and try to say if the stress index was elevated or not, meaning that the patient was being over distended. I think that we have to be careful with that. We have some cases, and actually I don't have one here, in which by just changing the flow rate and the settings, you can change the calculated stress index that is coming from the machine, which would be concerning. However, if you set the flow rate low enough, so that you and long enough to see the behavior of the curve, you may be. I think that could be appropriate, Miguel, as they did in that article. I'll put the reference later on here when we're done with this. Very good. All righty, thank you, Udi. Good observation. Trying to minimize the strain that these lungs are getting. All righty. The next one is a little bit harder. This one is a live one. I put this one as the teaser for Twitter, but it occurred, and I left a little bit of the mode there. I want to see anybody of our fellows wants to jump in.
Can try.
All righty. Go ahead. Is this a man?
Yeah.
This is a man. Let's give the audience just 30 seconds to look at it. Try to answer it yourself. Come to terms on what is going on with this patient. What is the tag? What is the load? And then what's the patient ventilator discordance that is occurring here? All right, then. Go at it.
All right. So the tag, in this case, the flow is reasonably well controlled. Looking at the flow waveform, it's not absolutely precise. Maybe the vent feature, the Q compensation issue, but it also says volume control. So I would say VC, CMVS. The load. So this is a decelerating ramp waveform. So if you're looking at, and the first breath looks pretty passive for the most part during inspiration. So I'm trying to focus on that to determine my inspiratory load. So I can see that in the initial instant of inspiration, the pressure is is higher than during the end of inspiration. So the initial part is more reflective of resistive pressure. So that's higher than the elastic pressure. So based on that, I would say it's resistive during inspiration. And during expiration, it's difficult because, after this breath, the expiration is not totally passive. But looking at the one after, and even the cutoff expiration from the one before, it looks pretty prolonged, and it's not reaching all the way to the baseline, even in 2 seconds that I can see. So I'm going to say resistive. So PV discordance wise, there's a couple things going on. So the first thing I look at is the flow waveform right after the breath cycles off. The first one is a little indentation towards positive indentation. This kind of looks like some inspiratory PMUS right after, but I'm kind of not sure because I don't see any inspiratory PMUS on the pressure. So it's difficult for me to call. I mean, if maybe there's some mild PMUS towards the end of the inspiration, so that would be, in that case, that would be early cycle. But I'm not sure. I probably wouldn't read too much into that blip. The big thing that I see, however, is that during the later part of expiration, the flow moves towards the baseline. So I think this is PMUS for sure. The patient's trying to take a breath in. And so this is a case of failed trigger right here, is what I would say. And essentially, I think it's a couple interesting things going on also is that in this case, the patient's trying to trigger the next breath, but since he has auto peep at that instant, the PMUS is against the auto peep, and it reaches right up to the point where it kind of matches the auto peep, so the flow is about 0, but then it's just not enough to trigger another breath. So then he lets go of the auto peep, and then there's this sudden increase in expiratory flow again, and that's why you see that positive blip on the pressure waveform as well at that instant. So that's the triggers, the inspiration. There's some work shifting in the second breath, which is an active breath. It's a patient-triggered breath. And cycle, again, maybe the first one is early, but I'm not going to read too much into it. And expiration, there's no expiratory work. There's this missed cycle, but for the most part, expiration's normal.
And the cycle, you said it was normal or early?
Maybe early in the first one. I'm not sure, but.
And now the $1 million question, not 1 million, there's no money here. But would you change anything on this ventilator?
Yeah, so we need to kind of, minimize auto peeps. So, I mean, the rate's already pretty low, but I want to know, is the patient sedated or what the patient's intrinsic rate is. So I would, if the gas exchange allows, I would really drop the set rate down so that the patient can trigger, each breath, and it looks like the patient's intrinsic rate is low anyways. So the first thing that I would do to minimize auto peep is to reduce the rate and then kind of see how the things settle down from there. Yeah, and then, other than that, it will depend on context and gas exchange, etc.
Very good. All righty. Very nice. Rob, are you on the line?
I'm here.
All righty, Rob. Okay, just wanted to be sure that you had arrived. So let's go over your thoughts. Amand, as usual, really insightful. Really appreciate your contribution. So you said the tag was volume control, and you appropriately recognize that the flow waveform is not perfect in your two breaths, and you recognize that this is a servo U, and that when we put in the tube compensation, it will modify how your waveforms look in the presence of effort in the presence of effort, trying to represent a simulated curve of what the trachea is seeing. That's according to their engineers. Then you have CMB. The breaths are mandatory, and we know that because this one is triggered by rate, so that definitely is a mandatory breath, and the other one is cycled by the tidal volume or the inspiratory time, which makes it mandatory. So this is definitely a mandatory mode. And then set point, as we discussed, there's no other feature that tells us that this would be a different type of targeting scheme like dual or IMB, at least in the presence of effort, which is it's a good amount of significant effort that occurred during the second breath. So I agree with you. Rob, any disagreements there?
No, it's nice that you have one passive breath and one active breath right next to each other.
Yeah. Well, let's actually talk a little bit about that. That was one of the comments that Tim did is, well, is it resistive? And I love that you recognize in the descending ramp how the initial peak would be consistent with an increased resistive load. And the question is whether this was a truly passive or the presence, and then you spent some time thinking about this blip over here that looks like an early cycle, or actually it could also be with the presence of those changes and the drop in pressure over here, if the patient was actually doing some work shifting, and this is an early trigger, which you commented on. So it could be. There's other features that you highlighted even better, which is the presence of mistrigger and the presence of not returning to baseline that makes us think that this is definitely resistive load. And that would go with that type of desynchrony and this finding on the waveform. So although there may be some early trigger hidden here, it seems that the resistance is definitely increased. So I would agree 100% with that. Rob, any disagreement there?
No, it looks to me like an early cycle as well on the first one.
Right, over here, right? So early trigger, early cycle, because there's no, it was not triggered by the patient. As you can see, this was pressure set to trigger by pressure, and it was not triggered here by the patient. It would be an early trigger. One breath is an early trigger there. And I completely agree with you that I think that this one over here looks like a failed trigger. So the patient, and that goes with the increased resistance. So a patient with increased resistance is unable to trigger breath. A failed trigger is consistent with auto PEEP until proven otherwise. There's other etiologies out there. There's no question about that. But very good. And then inspiration, as you mentioned, work shifting very well. So normally this waveform should have looked, if there was no resistance, it should look like this. And if there was increased resistance, that you pointed out, I erase now, come on, guys, it would look like that. Just like, so this is an increased resistance, and this is would be a normal one. But you can see all this area down here is consistent with work shifting. So the patient is really activating his muscles after triggering the breath. Cycle, early cycle, I think that's what you saw over here. I don't see it in the next one over here. So I would say usually early trigger comes accompanied by early cycle, but the cause is the early trigger, not the early cycle. So we would call it early trigger. And then expiration is normal. I agree with you. The effort that you see, this effort over here is because he failed and he tried to exhale at that period of time. I think that your choice of decreasing the rate is a good one to try to get rid of the auto PEEP. That's one of the ways to deal with that, no doubt. All righty, so there's a couple of questions. Before I move into the questions, Rob, any comments about this read? So we have BCCMBS with increased resistance, one early trigger, failed trigger, and evidence of some work shifting on the second breath.
I agree, looks good.
Okay, so we have a couple of questions from the team. The first one is Dilip asking us if this should be BCIMB, DDS, or DS. Rob, any comments there?
I don't see any indication of a spontaneous breath, so I don't know how you could call it IMV.
All right. Yep. I mean, and the ones that are spontaneous are not assisted, or well, they're not triggering, so we would not be able to see that, right?
Right. Yeah. If it doesn't pass zero, it can't trigger. I suppose you could say there's a potential for a spontaneous breath, but there's no evidence for it.
Right. The other point would be that when it triggered a spontaneous breath, it didn't get, it didn't cycle it by flow, it cycled it by time. So it would not be either under those circumstances.
Yeah.
So can the flow acceleration be selected with a decelerating ramp on the servo U? Rob?
Yes, I already answered that, yes.
Yes, and actually this is one of those that drives me nuts. You can, so this is normally this would be your square waveform, right? In the flow. And if you ask for a decelerating ramp, you would get something that looks like this nice triangle here. Well, in the servo U, and what you can set is not only the ramp, so you set the percent ramp decrease. Why this thing is there. So you can say it ends up at 40%, or you can say it ends at 70%, or you can say it ends up at 20%. Why? I don't know, Dilip. The other thing that you can do is, if you so chose, you can change the rise time. So instead of rising in zero, you can raise a little bit more inclined, or more inclined, you can change it. And so you can imagine now you can actually create a sinusoidal if you were trying to do that by changing the ramp settings. I have no idea why would we choose to modify any of these settings on a patient on volume control. And so I welcome any input from anybody that has a good idea.
Thank you for that. My question was mainly because I was wondering if on a decelerating ramp you could have dual active at the same time. And that's related to Juan's question there that could this be a reverse trigger that we're seeing in the middle of the first breath? I agree IMD is not likely from this waveform, but I was just wondering if dual can be active at the same time as a decelerating ramp, and Rob says no. So that answers my question.
So can you have dual active with decelerating ramp at the same time? So, but if you have a ramp, you can have the flow adaptation on, right, Rob, or not?
No,
You can't.
no. If you go under if you go into volume control and look at the flow settings, there's three little icons. There's a rectangle, there's a ramp, and there's a rectangle with the little dots on it. So the first two are set point, and the third one is dual. That's the flow augmentation.
But is that also on the Servo U? On the Servo U, I thought that you just had the flow adaptation button, and then you have the other settings for the. Do they get deactivated if you set a ramp?
Yes.
Okay, perfect. Woo! We learned another thing. Servo U secrets.
Yeah, because that would confuse me. Like if you have a decelerating ramp and dual kicks in between, I don't know how you could say that dual was not active on the first breath. Yes, it looks like resistance, but I don't know. I would wonder if you can have that active, but sounds like that's not even possible. So that's actually great to know.
Yeah, good
So,
knowledge generation.
Quick comment. Eduardo, I don't know if you remember, there was this case shared on Twitter where I think there was an Avia ventilator or some other ventilator which had that option with a decelerating ramp, and we were kind of like talking about how that can cause problems. So I don't think it's an option here, but maybe some other ventilators it may be.
Yeah, that's a great point, Aman. There's every ventilator is its own world in many ways. So that's a great point. I have a comment here from Juan Martin that asks, could this be a reverse trigger? And yes, Juan Martin, for us, early trigger equals a reverse trigger. We just use the denomination of early because reverse trigger is mechanistic, and there's many causes for a reverse trigger, for what it's called a reverse trigger. And so you have heard us talk about different phenotypes. And as people are learning more and more about this phenomenon, it's better for us to have a non-mechanistic etiology than a mechanistic etiology, which would be reverse trigger. I hope that makes sense. All righty. Excellent. All righty. I have another one. I'll ask, while the team observes, is there any of the fellows that wants to give it a try? Have no fear. If there's a bunch of fellows in the room and you guys want to do it as a group, that's okay too.
I can give it a shot, Dr. Mireles.
All righty. Okay, so before we start, just for the team, remember, look at the tag, what is the load, and then go in order of the discordance. That will help you go systematically through it. So challenge yourself a little bit and think at the end of this, what would you change on this patient? That's the key question. And for this one, I put actually all the settings on the bottom on the side so that you don't say that I'm sabotaging the mission. Alrighty, go Ahmed.
I'm gonna start with looking at the tag. So you can see that the patient is, let's start by looking at the flow and pressure waveform. You can look at the flow waveform and you can see it's not geometrical, it's not controlled. So this is pressure control by exclusion. So to start with, this is PC. Now, every breath is triggered by the patient. And when you look at the size of each individual breath, they are variable in size as well and duration, which tells me that the patient is cycling as well. So the patient is triggering and cycling, which would make it CSB. And then when we look at targeting scheme, I think this is set point, and I can use the little help that you have down there. So we're setting the pressure, support, and the PEEP. So that will go with set point. So this is PCCSVS. Now, when I start looking at the load, since this is pressure controlled, I will look at the flow waveform to determine the load, because we're theoretically controlling the pressure waveform. So you cannot decide by looking at it. So I'm going to look at the flow waveform. You can see a lot of inspiratory effort, so you don't see a nice decelerating waveform. You don't see the scooping. You rather see this waveform that's indicative of PEMAS. So there is PEMAS as a load and inspiration. I think there's expiratory work as well. So I'm going to say PEMAS and expiration as well. Now, in terms of PV discordance, we can see that with the inspiration, there's a significant drop in pressure. It's flow triggered, but there's still a very significant drop in pressure. So it makes me wonder if there's any delay in the trigger, but it's happening almost at the same time. So I think it's just the effort that the patient is doing. So I'm going to say that the trigger is appropriate for the most part, acknowledging that the patient is doing, is sucking very hard to trigger the breath. And then in terms of inspiration, there's work shifting. Well, is there? Let me see. What's the peak pressure there? I mean, there's evidence of work. So I'm going to say maybe some work shifting. And then eventually there's the peak at the end of the pressure waveform, and you start wondering if this is early cycling, delayed. Yeah, if this is like delayed cycling, or if this is basically the vent trying to adjust for the pressure swings with the patient effort. And I can't really see the number on the pressure waveform to see if it's like peaking too high or not. And since this is a pressure support mode, meaning that the patient is cycling, I'm going to rather go with it's the vent trying to adjust for the pressure. So when the patient starts the breath, he's doing a lot of effort, he's sucking really hard. So the machine is trying to pressurize. And then when he relaxes to exhale, it overshoots. So I'm going to say cycling is appropriate for now. And then expiration, there is work. Thank you.
Ahmed, what would you change? What would you do with this patient if you see this? Are you there, Ahmed? I think you may have muted. He may have hung up. Ahmed, if you're still there, what do you think about this thing here and this little thing here? He probably hung up without intention. All right, let's read this one. I hope that you, Ahmed, if you're listening to me, that would be great. This is
I'm listening. Sorry. So I think these are failed triggers right there. I mean, he's doing an effort. He's getting a flow waveform almost to the baseline without being able to trigger. So and there's actually as well a drop in the pressure at the same time. So the first one is definitely a failed trigger. The second one is happening right after the end of the breath, which makes you wonder if this is some sort of early cycling at that point, because it's trying to continue to take a breath, but the machine is have ended the breath.
very good. Thank you, Ahmed. Great as usual. Very eloquent on your explanation, so appreciate that. So definitely pressure control. We agree with you. And CSB, as you read these different items with evidence of patient-triggered breaths, and the cycling is being done by the patient, and it's set point, because we set, as you appropriately observed down here, the amount of pressure support above PEEP and the PEEP that the patient is getting now. You read this as this patient is doing a fair amount of activity during inspiration, and you can see how during the whole process of inspiration, the patient is active and is pulling a fair amount of tidal volume. And then during expiration, actually, instead of having that beautiful decay, it's all of this is patient effort throughout the breath. So large amount of activity going on there. In terms of trigger, I dare to agree with this, that the amount of work that this patient is generating to generate the flow change to trigger it looks substantial on this image. It looks like the patient is doing a fair amount to drop it. I definitely agree with your interpretation that this one over here is a failed trigger. The patient dropped a lot to generate that. So it starts making me think, why would this patient have so much effort to trigger and have a failed trigger in the middle of the breath? I mean, you can see how he finished this one and then he tried again to breathe in, dropped the pressure and was not able to get there. Yes, Dilip, that why didn't it trigger? And it may be that they set the peak the flow threshold higher than to achieve it. So it's remember, the gain on this may not allow you to see how much higher you have to go to trigger the flow change. In terms of inspiration and work shifting, and we're gonna come back to the trigger because I think that there's much more to talk there. But you're at a 5 of PEEP and the pressure is set at 5 above, which probably would be around this level here for this patient. And so what you recognize as these bigs are just the simple change that the patient is having rapidly. You can see that as he crosses the flow, there is no evident pause that would tell me that this is a late cycle causing this peak. So I would agree completely that this is just an artifact, pressurization artifact as we're going down. But there is this one over here that you pointed out. Let me erase so that we can see it more clearly. That also made me wonder for a while if this was actually a manifestation of him having a longer, and this is an early cycle, or if it was another effort that happened after this one. But I think that I'm gonna go based on the curvature here, that this is a early cycle for this patient. But it could go both ways. In the absence of a esophageal balloon or an EDI or a diaphragmatic signal, it would be hard for me. So I would also agree with you that the majority of them are normal, but this one over here is probably an early cycle. And then expiratory work. Rob, what are your thoughts here?
I would have to agree with you. That looks like an early cycle to me as well. The patient apparently has inspiratory effort all throughout the inspiratory phase, and towards the end of the inspiration, he can't generate enough flow to keep it from cycling off. It looks like it'd be interesting to know what the cycle threshold on this thing was.
Yeah.
Looks relatively high.
Absolutely. There is something there. It also made me think, whenever I have a failed trigger, I think about if there's an increased resistance on this human being. And that's probably why he's generating so much pressure to trigger the flow change, or exhaling as hard as he is to trying to overcome a resistive component. But there's so much PMOS that I cannot see that.
Mm-hmm.
And so that hides what the physiology may be, and the problem may be just an ET tube that is obstructed, as we have seen in our COVID patients and others. Or is it an anxiety, pain, delirium, or whatnot? I see a comment from Dilip. Is it Yunus editorial? Another artifact? Well, it's an artifact of pressurization. That's what the Yunus editorial talks about, Raman. Is that it's not an active issue. It's just the ventilator cannot maintain the pressurization, so you get the spike on pressure at the end of the breath.
The question.
Yes, go ahead, Ahmed.
Trying to figure out why with the missed trigger, there's a quite noticeable drop in airway pressure. Because for the most part, I mean, the flow waveform, it's basically a retardation of expiratory flow. There's maybe this one instant where there's, the flow waveform crosses the baseline into inspiratory, but for the most part, it's just a retardation of expiratory flow. I'm not clear why there's a drop in airway pressure in that instant.
Well, he generates a lot of effort, right? So I presume that the PMOS here is a pretty darn good amount of PMOS going down, and that generated the drop, the change in flow, and the change in pressure. Now you would argue, why didn't it maintain the pressure at the level and trigger another one? Is that your question?
Yeah, and I mean, I'm just trying to think like mechanistically, like if I have like air trapped, in the lungs, and I try to inhale. I mean, this is basically in the middle of exhalation. He has PMOS, so it's basically going to be, retardation of my expiratory flow. The only way I can see there's a drop in airway pressure if I'm actually sucking air from the circuit. That'll cause the drop in airway pressure, which again, I mean, it just reaches the baseline at one small instant, but the drop in airway pressure is over a longer period. Like normally when I see, like even in the last case when you saw a missed trigger, it wasn't like a huge deflection in airway pressure waveform. I don't know if I'm not thinking correctly, but
I don't think it's as simple as that, because there's always a baseline flow, and there's always an interaction with that baseline flow, the exhaled flow, and the exhalation manifold. They're all working together to give you the PEEP. So, when the patient makes that inspiratory effort, the flow going through the exhalation manifold decreases, right? In fact, at some point it's zero. And for a millisecond, it's zero. So the ventilator can't generate any PEEP if there's no flow going through the exhalation manifold.
Gotcha.
Of course, it's more complex than that because it's all dynamic. It's all happening out of phase, and it's crazy, but it's not as simple as just, a static system that you suck gas out of.
Okay.
Yeah. So when I agree with that. I'm wondering again, and I'll just highlight if why is this patient doing this, and is this a issue with PEEP, with resistance or something else? I cannot tell clearly. Very good. All righty. Well, we have one more. We have 17 minutes, so I think that we can achieve that. Let's do one more. Anybody wants to jump on this one and give it a try? All right. Well, let's do it together. This one is another patient in the ICU, and we can see that he's on pressure support CPAP. Similarly, you can see the PEEP and pressure support being set here, and just by looking at the waveforms, you can see that the flow is different in each one of the curves, which tells you that that it's not being controlled. So it has to be pressure controlled just by looking at that. And then it's triggered by the patient. And again, this is another patient with pressure trigger. And you can see that there's three breaths that got, 1, 2, 3, 4, and the beginning of the next one, six breaths that got triggered by pressure. And so the patient, and you can see the pressure dropping from there. So this is CSB. And it's set point, as we know, because we set all the variables on the ventilator. We set the pressure, the inspiratory pressure that we're going to go up to. What is the load? And when you're looking at pressure control, you're looking at the flow waveform, and immediately you can see that there is evidence of PMOS. Instead of looking very nice like it should with a decelerating waveform like that, what you see is this curve that looks sinusoidal, just demonstrating the activation of the muscles in this patient. So during inspiration, I cannot tell you what's the physiology And during expiration, similar to the prior one, there's evidence of activation of the respiratory muscles. So it would be hard for me to actually tell you what's the physiology on this patient. I can only say that it's PMOS. In terms of triggering, so you can see the drop on pressure starts up here, and it takes a fair amount until they reach from baseline, the triggering, and then it activates. So actually, it looks like this would be a case of late trigger, in which it's just taking a large amount to do that. And the cause of that, just by looking at it, it's likely that they have set a pressure trigger, and that is causing the patient to take a while. Actually, you can see here, if I amplify this, there's a way to do that there. Look at that. You can see how the flow has crossed. It takes a while until it pressurizes. It takes a while to cross, and then it pressurizes. So we're able to see it on this graph, but it took a fair amount to do that, and that's why there's a delay on the amount or late trigger on this patient. Then you have inspiration, which for all criteria, you would probably say that there's work shifting, because some degree of work shifting is not severe. The pressure is not dropping below baseline, although there's a lot of work, trigger work, not necessarily during inspiration, but during this period, there's trigger work. Then the cycle flow crosses very nicely, and there's no evidence of a pause when it's doing this. So I think that this would be a normal cycle. And then there's evidence of expiratory work. Now, the area that caused a little bit of pain in my brain when I was looking at this is this area over here. And you can see the patient did an effort, got the pressurized, and then as he started exhaling, he started a new breath rapidly with a lot of effort. You can see how he dropped his pressures almost below baseline. If this is 0, it dropped it below baseline, and then it got pressurized rapidly, and the breath ended, and it went out. And I could not read necessarily what happened to this patient. You see, he got a very tiny tidal volume after he exhaled, and then he got this thing here. So I wanted to hear from the group, what did you think happened here? What do you think is going up? And so a man says, is this a hiccup? Dilip thinks, is this a cough? Anybody else? Yeah, I think this would be one of those situations in which I don't think that the PMOS was going from here all the way to here. I think that the patient had one PMOS that went around here, and then he had a large, small effort that went up and down just like that. That's a good question. Why is this not early cycle? And that was the key question. And so I want to hear from the team, why do you think that this would not be an early cycle? Good question, Mamta. That's a great question. Anybody? So I think that if it was an early cycle, Mamta, yeah, you would not expect the flow to have terminated so nicely here. You would have expected the patient to have continued, then something cycled the breath, and then the other breath came up. My God, I'm making there a mess. Let me erase up everything there. Oops.
Also, in pressure support, an early cycle would probably be caused by a very high flow trigger threshold,
Right.
like 80 or something like that, but I don't see that happening here.
Right. You would expect it to, if the breath was ending around here.
Yeah.
Here, but it's not. It's terminating all the way down. So there's no evidence of continuous flow and then something terminating it, and then you have your. So, yeah, I think that's a patient. That no doubt, Miguel, that's a patient-initiated breath. So that's why we think that it may be a cough or a hiccup after that breath afterwards. So, very good. So
Can I ask you a trick question?
Yes, go ahead. Trick me.
If you look at the settings at the bottom,
Yes.
you can set a backup respiratory rate. Now, someone might look at that and say, well, if you set a rate, isn't that a mandatory breath? And if you set a mandatory breath, doesn't this make this mode really IMV? How would you respond to that?
Well, actually, we have a picture of this happening, Rob.
Mm-hmm.
And I see Al is on the line too. So this was interesting for us. I always had a question about this little icon up here with these little arrows back and forth, which would tell you, well, this patient can go back to pressure control and back and forth. And so we had a patient that we had on pressure support went apneic and then went on to the backup rate, right? And the backup rate activated, and contrary to all the usual ventilators that we use, not all, but many of the ventilators, whenever you go into apnea ventilation, the ventilator stays in the apnea settings until somebody comes and presses the alarm button and says, shut up, and you get them back to pressure support. But that did not happen here. It alarmed, but as the patient started breathing again, startled by the alarm, the ventilator shut down the backup and it went back to pressure support, effectively turning into IMB.
Yep, effectively is right, but not by classification because the alarm went off.
That's true. So
taxonomy is only to normal operating conditions. Otherwise, the taxonomy wouldn't work. It'd be too complex.
Correct. So,
but when it went back from,
go ahead.
Oh, sorry. But when it went back from IMV to spontaneous, isn't that an evidence of intelligent or a rule-based flip back into pressure support?
Yeah, but it was based on an alarm. So when it's alarm triggered, we don't change the breath sequence on the classification, right, Rob?
There is a rudimentary intelligence there. It allows basically the patient to cancel the alarm and go back to where he was. That's very rudimentary, but like Eduardo says, the taxonomy is built around normal operating conditions. And I just checked the manual, and it does say that that's an apneic period. You set an apnea period. If the apnea period is triggered, then you get an alarm and you go into the backup rate. So that's just a red herring there. Eduardo, when you have auto mode, it says auto mode, right?
It does.
And do you still get that double arrow with the auto mode?
Yep.
It'll be white then. It wouldn't be. It wouldn't be blued out. Right?
It moves according to the breath that it delivers.
Yeah.
Color. So it's white right now where it says pressure support CPAP, but if it was delivering a mandatory breath, it would highlight the PC. It's actually
that's pretty cool. Yeah. Very good.
Well, we're about to finish. I just want here's for those that get CME. Pick up your phone and you can do this. This is the CME for the CCF caregivers. I will tell you that we just put out in PubMed a article that actually describes everything that you went on through today. And so I know that we will tweet it at some point. I know this is it's the preprint, so it has not been proofread, but it's the article is out there with the whole process, waveforms and whatnot of what you just did today. So please read it if you and obviously send those comments if you have any other thoughts there. Thank you very much, and great as always. I want to congratulate Aman for his input, Udi, Majumdar, and then Gohar, Ahmed Gohar for their amazing reads. Thank you very much. Have a great day.